Good morning, everyone. This beautiful morning of Saturday. And we are having this small discussion about academics. And this will be a kind of interactive session. I hope some postgraduates are also here. That would be nice if I can interact with them. Yeah, so I have no conflict of interest in this presentation. And in this presentation for next few minutes, I would be talking about these 4 things basically in triple negative breast cancers. That is clinico-pathological characteristics of TNBC, the subclassification, histomorphological as well as molecular classification, few words about that. My experiences on TNBC and research predominantly on cancer stem cell markers and the further current trending research in TNBC. So in this session, I'm going to talk only about the basics, but not much about molecular, but a little few pointers on molecular. Because in the next session, if somehow we are going to have in future, we are going to talk in detail about the molecular aspects of TNBC. So what is triple negative breast cancer? You must all be aware that a cancerous cell which has no ER, that is no estrogen receptor, no progesterone receptor, no HER2/neu receptor, we call it as TNBC, and this type of category of tumor, they require more intensive treatment. So the breast cancers which show the lack of immunohistochemistry expression of ER, PR, and HER2/neu. So lack of IHC expression or absence of IHC expression means what? When the percentage of ER is less than 1%, the percentage of tumor cells showing PR is less than 1%, and HER2/neu score is 1+. So a cell which lacks these 3 receptors comes in the category of TNBC. So what is the cutoff for IHC for ER and PR? This is basically for the postgraduates because there are different cutoffs which keeps on changing. So there was an old guideline of 2009 that 1 was less than 1% nuclear staining and 5 was 67 to 100% of cells showing the nuclear positivity. So it ranged from 0 to 3 and then according to the staining and weak staining. But with time, the new guidelines came up, and now what everyone is following universally is the tumor cells which show more than 1% of nuclear positivity is considered as positive in both ER and PR. This is according to the 2020. So I think all of you who must be signing out the breast cancer reports, and I think IHC is mandatory, the ER, PR, HER2/neu is mandatory in that, you all must be following these new guidelines. If not, we need to follow this more than 1%. So I'm taking a pause and, making it more important so that it is engraved in our mind that even if 1% of tumor cell positive for estrogen receptor or progesterone receptor is considered positive. So just few pictures from my sign out reports. This is a case of breast cancer, and here we can see beautiful ER positivity. You can see these cells, these show the clear-cut nuclear positivity. So it is clear-cut, definitely more than 1%. So Satish raised a hand. You would like to ask question right now, Satish? Or you can ask question in the end, it would be better. You can pop your questions in the chat box and then I can answer in the end, okay? So the cells showing the nuclear positivity. So this is considered to be ER positive, and here not even a 1% of cell is positive for ER. These are some pictures I would like to show you from our sign out reports. This is also a case of breast cancer where we can see the beautiful PR positivity, nuclear positivity. So now the cutoff of IHC of HER2/neu. There was also old guideline of 2009 where we considered that the cells showing the membranous positivity in more than 10% of tumor cells. But again, with time, the guidelines changed and now it is 2018. I'll go from high positivity to low positivity. In IHC 3+, that is 3+ membranous staining of HER2/neu. It displays complete intense circumferential membranous positivity in more than 10% of cells. 2+ weak to moderate staining. 1+ is faint and 0 is no staining. So now the most important point in relation to TNBC here is that If it is 3 plus, it is HER2/neu positive. If it is 1 plus, it is HER2/neu negative. But if it is 2 plus, that comes in the category of equivocal. Now we stand up confused. What we should do? Anyone? Because this, if it comes this is TNBC. If it comes in this category, it is definitely non-triple negative, means positive for HER2/neu. But what do we do if it IHC is 2 plus for HER2/neu? Anyone? Any postgraduates like to say something here? Yeah. You can give your responses in the chat box. Yeah, fish. So Varun Singh, you're perfectly right. The answer is fish. Okay. So now is the trend, latest trend here is that if we are giving IHC 2 plus for HER2/neu, we have to advise fish for that. Okay. So I am again coming to our topic of today. This was just a basic. So for routine IHC of breast cancer, 1 plus is TNBC. And 3 plus is positive. So this is the latest guideline we all follow. And please keep in mind, IHC positivity is always for HER2/neu is membranous positivity. So this is a beautiful picture of 3 plus. We can see a beautiful membranous positivity in this cancer cells. Okay, you can clearly see a crisp, clear-cut outline of a membranous positivity. And here the cells are negative for that. So based on ER, PR, and HER2/neu expression, the breast cancers are categorized into TNBC when all three are negative, and non-TNBC with all these permutation and combinations. Like if 2 are positive, 1 negative, if PR negative and HER2/neu negative, only 1 is positive. So either of these permutation and combinations comes in the category of non-TNBC. So today we are talking about this category and what are the inference of this category, what is the significance, and why we are talking about TNBC today. Why we have a separate session about this entity, what it is, why it is important for each one of us, because there is no target therapy available commercially right now. Upcoming is there, research is there, we are going to talk about that, because they are ER/PR negative, so hormonal therapy does not work on that. That is tamoxifen and aromatase inhibitors. It is HER2/neu negative, so trastuzumab and lepatinib also do not work on that. So that's why TNBC is more important, and we are talking about that. So this is a beautiful picture of the nature. You can see these beautiful mountains, lake, and plants. And let me know from where this image is. Any city you can come in mind. I would be showing more pictures of the city later. So coming on to the first aspect of TNBC is demographics. TNBC constitutes 16% of all invasive breast cancers. For example, you have taken a cohort of 100 cases, out of that around 16% are TNBC, but this percentage vary according to the research. So this 16% is according to the research by Rakha et al. In 2007, but after that many research have been done. In fact, we have also done a research. I would be sharing the percentage with you. And some people say it is 15, but there is a range. It is 15 to 25% or 26%. So out of these TNBC, 88% are invasive ductal carcinoma, no special type, IDC NOS. So out of all the TNBCs you are signing out, majority of the cases, like 80% or 85% or 3/4 of the cases are IDC NOS type. And we have the latest reference for this in 2020. So I would like to share my experience of demography of TNBC. I took out 1,142 cases. This was 1.5 years duration. It was Jan 19 to June 20. And out of these 1,142 cases, 274 were TNBC. So now the percentage what I observed was 24% as compared to the previous percentage of 16%. So as I told you, the percentage vary. So my experience was 24%. And out of these 274 TNBCs, I found out that IDC correspond to 211 cases that correspond to 77% as compared to this, that's 88%. So this also varies a bit. So out of these 274 cases, 77% was IDC. The second most common was neuroendocrine, that is 4%. The third most common was metaplastic carcinoma, and SCC was in that. The mucinous carcinoma, however, mucinous carcinomas are not much. That is a very minority of percentage. Medullary carcinoma, lobular and mucoepidermoid carcinomas. So you must be wondering that many morphological subtypes are absent in that, and I would like to tell you why. But this is my observation in these cases of 1,000 and plus. So IDC was predominant, neuroendocrine, metaplastic, and then the minor categories type. So the two things what in demography we came to know in this research is that TNBC correspond to 15 to 25% of the total cohort of breast carcinoma, and out of TNBC, IDC is the most common. However, neuroendocrine, metaplastic, and other types are also there. So TNBC is more common in young patients than other types of invasive breast cancers. This is according to the research given below. And the most important point, again, why we are talking about TNBC today? Because first of all, it is not responding to any other hormonal therapy or trastuzumab, etc. Plus, these cohort of patients, they present at higher stage. They present as a large tumor size. They present with metastatic disease as a diagnosis, means the patient come to the OPD when the breast cancer has already migrated to the other areas than the primary. And they also present at high rate of node positivity. So you can see high T, high N, and high M. So they present with high T and M stage. So that's why we need to diagnose these tumors at the right time. But this is the main clinical presentation, which is according to the research done with the people. Like this is a research by Bauer K et al. It was in 2007, and that another one also as 2007. So they are a category of aggressive tumors. They are associated with low survival rates. They have an increased risk of recurrence. And a lot of hormonal factors also play a role in TNBC, like the young females who are less than 40 years and who are on OCP use are at increased risk of TNBC. As compared to the nulliparous women or the lactating women, they are at the decreased risk. So these are the hormonal factors which play the role in the presentation of triple negative breast cancers. Another significant point is that TNBC commonly present with high grade, that is poorly differentiated or the high grade. Okay. So this is according to this research in 2007. But as I told you, I also did a research. So we did this research. I will be talking about this research in detail. That was my research on cancer stem cell markers in TNBC. But we compared that with histological grade also. And my observation was that TNBC showed higher histological grade as compared to non-TNBCs. So 35% were associated with grade 3 as compared to 25% of non-TNBC associated with grade 3. So this is in consensus with the research which has already been carried out. So this is another picture of the nature from the same place. You can see the beautiful coconut tree, lakes and mountains. And now we're coming up to the morphological classification. So as I told you in my research, the various morphological classifications, some of them were missing, and now you can know which are the missing. They say that low grade and high grade is that we can divide. High grade comes the IDC type, the squamous cell carcinoma or metaplastic carcinoma, spindle cell carcinomas, carcinoma with medullary features, and the low grade are adenoid cystic, secretory carcinoma, fibromatosis like metaplastic carcinoma, low grade adenosquamous, and tall cell carcinoma with reverse polarity. So now I ask a question that the research which I did, I am going to show you the picture again. This, yeah. In this, the IDC was most common, and neuroendocrine, and then metaplastic carcinomas. Are you wondering why the low-grade tumors are not common in this? Why the first category of tumors are not common in this one especially? Because anyone would like to give the answer? That when I saw the morphological types, only these categories were common. I could not find any of these cases. Anyone who are listening right now, any postgraduates or residents? You can make a guess that suppose if in future you are going to do a morphological study about TNBC, what are the type of morphological types you will find? I could not find any of the low grade type because TNBC always, most of the time, present with high grade, right? That is the reason, because they present with high TNM state, they present with high grade morphological grade. But this is the study done by Sang et al. In 2020, and they found out these morphological types are low grade and these morphological types are high grade. So this is a few pictures of IDC, some morphological pictures I would like to show you of inflated duct carcinoma. This is grade 3. You can see these tumor cells, they have high NC ratio. At some places, they have prominent nucleoli also. They have high degree of pleomorphism, apoptotic bodies, and mitosis. So this was signed out at IDC, grade 3, it was TNBC. Another interesting case I would like to show you, a 47-year-old female came with the right side breast mass. Biopsy was done straight away. The histopath report, you can see, these are the cells at, it is 20x actually. And they show the tumor tissue which are arranged in diffuse sheets with small round oval cells. And some places we can see a little bit of necrosis also and hyalization also. And you can see these cells which are present in diffuse sheets. And on high power, you can see these cells which are having hyperchromatic nuclei, and they have scant cytoplasm. You can see there are no prominent nucleoli as compared to the cells you just saw in IDC. And some places there are some attempt to rosette or pseudo rosette formation, you can see here. So anyone ring a bell? What is the diagnosis of this case? And these cells were ER/PR HER2 negative, so they were TNBCs. So anyone would like to say what is this type of morphology? Yes, I'm getting a response. Say, yes, Swati, you're perfectly right. This is a neuroendocrine carcinoma. So it was signed out as a neuroendocrine carcinoma. And on the top of that, Varun, you're also right that these cells were NSE positive. The picture is not so good. I apologize for that. They were CD99 positive, and I could not show the picture for synaptochromo CD56. It was positive for that too. So it was a diagnosis of neuroendocrine carcinoma, which was triple negative. Okay, so this is a picture I took from the web. This is a case of metaplastic carcinoma. As I told you, the third most common, which comes in the category of TNBC, the morphological types. So this is a beautiful picture from this reference. We have to see it very nicely when we go from left to right. These are carcinoma with medullary features, NST, high grade, apocrine, secretory, adenoid cystic, low grade. When we go from left to right, the aggressiveness and the prognosis increases. Okay, it is low grade to high grade. Why? Because you can see a word here that is TILs, tumor infiltrative lymphocytes. I would be talking about TILs in future in the coming slides, because the case here have high degree of TILs. So a breast cancer which are triple negative but have high TILs are a good prognosis. So as we go from left to right, TILs keep on decreasing. As we go from left to right, the grade keeps on increasing. The aggressiveness keeps on increasing. The prognosis is becoming bad. So some more features about TNBC. On gross, they have pushing borders, poor differentiation, high grade, as I told, high degree of atypia, necrosis, and lymphocytic stroma, and they are ER/PR HER2 negative. Okay, so this is the same experience as I told you. So these are the morphological types I saw in my study. So this is another picture from the same city, and now you all must be knowing I'm talking about which city, but in the end, I'm going to tell you. So this is a, you know, what is this picture? This is a famous Jain temple. Okay, so TNBC is not a single disease. Rather, it is an umbrella term for different subtypes, different morphological types, and different histological types. So breast cancers as such, this is very important. So all of you need to pay attention here. Breast cancers are molecular classification as such. They're divided into luminal type of cancers and HER2 positive. In luminal, we have luminal A and luminal B. In HER2 positive, we have this category of cancers which are HER2 positive, and ER/PR could be plus or minus. But the next category is TNBC, which are basal-like breast cancers and non-classified subtypes. So we would be paying attention to this last category here, TNBC, which are basal-like breast cancer and non-basal-like. Okay. So this is another presentation of molecular classification of breast cancer, luminal type A, B. So these are the surrogate markers like ER, PR, HER2/neu, what we routinely do. We do Ki67 as well, CK56 and EGFR. So if you do all these 6 IHC markers, surrogate IHC markers, we can classify breast cancers into these molecular subtypes. That is luminal A, luminal B have 2 categories, HER2 positive and TNBC, the basal-like subtype. So one most very important type. Many people say that TNBC is a synonym or an alternative to basal-like breast cancer, but that is not true because 80% of triple negative breast cancers belong to basal-like breast cancers. 20% do not. And basal-like breast cancers are defined by gene expression profiling. So if you see this picture, this circle, blue circle correspond to TNBC. The brown circle correspond to basal-like breast cancers. Okay, so only the 80% of categories are TNBC. The rest here, which are non-basal-like, correspond to 20% of the category. So these 20% of tumors, they are Claudin low type, normal breast-like, and apocrine type. Okay, and the third circle, that is a green circle, is BRCA1 mutation, which I'm going to discuss later. So now we are coming up to the most important part, but I would tell you that I would not be discussing this in detail because today we are talking about the basics of TNBC. That is the molecular classification. So in 2011, TNBC was divided into 6 molecular subtypes. Basal-like 1, 2, immunomodulatory, mesenchymal, and MSL, mesenchymal stem cell-like, and LAR, that is luminal androgen receptor type. So the same person, Lehman et al., he revised this classification in 2016 and he deleted 2 subtypes. He deleted immunomodulatory and mesenchymal stem cell type. Okay. So immunomodulatory was minus in 16 and mesenchymal, that is MSL subtype, was minus in 16. So this is the most important point for the residents listening here or young faculty listening here, that this is a revised classification. 2016, we have only 4 molecular subtypes of TNBC, BL1, BL2, M, and LAR. Okay. So now the most important, the second aspect of our presentation is associations of triple negative breast cancers with IHC markers. So I would be talking about 5 IHC markers as of today. First is cancer stem cell markers, in that CD44, but there are other cancer stem cell markers like CD133 and CD24 and CD49F, ALDH1, but I would be talking about 44 in detail. And androgen receptors, PDL1, BRCA, the spelling is wrong, I'm sorry, it is BRCA1 and 2 and Ki67. So this is a beautiful meditation room in the same city. So a person when spends even 2 minutes in this room can experience the calm and relaxation. So you can, if you visit the city there, you can see this meditation room. So cancer stem cell markers and CD44, I'm talking about in detail about our institutional research. So this is a part of intramural project in MAMC where I was the principal investigator. And this article, this manuscript is already accepted in IGPM. So what we did in this research, we found out the role of cancer stem cell markers in TNBC and its association with clinico-pathological parameters and angiogenesis. So we found out the expression of CD44 specifically in TNBC versus the NTNBC. And these cases were associated with histological grade and angiogenesis. So we took 58 cases and we took the comparable number of cases like 28 for TNBC and 30 for NTNBC. Out of these 28 cases, 22 were CD44 positive and 6 were negative. Out of 30 NTNBC, 16 were positive and 14 were negative. So you can say that the percentage of cases positive for 44, the cancer stem cell marker, is high in TNBC. So this is a pie chart. We can see out of 28 cases, we have 78% of cases which are positive for cancer stem cell markers and 22% were negative for CD44. So this was our observation, and this is in consensus with all the research happened before. And out of 30 non-TNBC, 55% were positive for 44 and rest were negative. So if you compare CD44 positivity was more in triple negative breast cancers. So how did we find out 44 interpretation? This is very important for each one of you. I'm going to ask one question here. Does any one of you do routinely 44 in breast cancers when you sign out? Anyone? Or it is only according to the research? Or any one of you have ever done CD44 in breast cancers? Anyone? I'll see the chat response if some of you would like to say. Because in my knowledge, it is not routinely done. I think we did this research, but now we have started putting CD44 routinely in the breast cancers. Okay. So what is the type of staining pattern we followed? 0 negative, 1 mild, 2 moderate, and 3 strongly positive. And positive staining was defined as minimum 2 plus circumferential membranous staining. So most important, please see it is also membranous positivity in at least 10% of tumor cells. So this is according to the guidelines by Pitule et al. In 2014 and also about Alexander B. by 2020. So this is the latest guidelines universally followed everywhere, that more than 10% of cells are positive for 44. So I would like to show you some pictorial representation. So this is a beautiful picture. This picture is very close to my heart, and you can see a very crisp, very nice membranous staining. The cells outline is very, very clearly visible in this. And this is 3 plus positivity for CD44 in TNBC. And I would also like to show you 2 plus positivity as well. So this is a 2 plus positivity. Here also we can still outline the membranous cells. This is 1 plus positivity, faint, weak to moderate, and this is negativity. We can just see the dab, but no outlines are visible in these cells. Okay. So the first outcome of our study was that cancer stem cell marker 44 was expressed more in triple negative of breast cancers. Okay, so coming on to the next part of our research is that we compared the microvessel density, and microvessel density was 9.73 per millimeter square and 11.15 per millimeter square as compared to the TNBC and NTNBC, and it was not statistically significant. So we put CD34 to find out the MVD, and these vessels are beautifully highlighted by CD34. So we also compare TNBC with the histological grade. So here we have a significant outcome. Grade 2, we have 64 to 73%, but grade 3, you can especially see 35% of TNBC are grade 3 as compared 27%. So the outcome we can take is that the high histological grade was associated more with TNBC because 35% as compared to the 27%. So the conclusion of research specifically about cancer stem cell marker 44 is that cancer stem cell marker 44 was expressed more in triple negative breast cancers, and TNBC correlated with high histological grade. And maybe in a few months, you're going to see this research in IGPM because it is accepted few months back. So this is a Peace Park in the same place which I'm going to show you, the same city. This is a beautiful park full of nature and full of plants, and you can enjoy that nature. So now we come to the second aspect of TNBC, as I told you, cancer stem cell markers, and the second one is PD-L1, because PD-L1 is a very, very upcoming IHC marker. It is done in every organ. It is well established in lung, but it is also being done in breast as well. So PD-L1 is expressed in 20% of TNBCs. Why we are talking about PD-L1? Why we are putting PD-L1? Because PD-L1 is a therapeutic target, because we have some drugs available which are anti-PD-L1 and which we can work in these category of patients. So additional investigations are still required to make it very, very established, but at least it is present in 20%. So this is a beautiful PD-L1 positivity, again the membranous one in these breast cancer cells. So I thank Dr. Preeti, my friend who shared the picture with me. So old guidelines said that more than 5% of cells should be positive, but the new guideline of PD-L1 is the same as ERPR, that is more than 1% of cell positive by 2022, according to this reference, which I have shown here by Sunil. So the therapeutic targets of PD-L1, the cells which are positive for PD-L1, we have these drugs available, that is atezolizumab, avelumab, and Keytruda. Keytruda is a combination of three drugs, that is paclitaxel, nab-paclitaxel, carboplatin. And the cells which are positive for PD-1, pembrolizumab is also effective in that. So now you are aware that why this research of PDL1 and TNBC is going on, because we want to establish the management, the drugs available, because it is not responding to the routine drugs of hormonal therapy and trastuzumab. So the third research is about TNBC versus the androgen receptor. So we can see the beautiful nuclear positivity of androgen receptor. This is a picture taken from this article of Modern Pathology. And the molecular subtype, as I mentioned, the LAR type, luminal androgen subtype, it is associated with better prognosis. It is associated with better prognosis and chemotherapy responsiveness. Why we are talking about AR? Because we have drugs available. That is bicalutamide, enzalutamide, and abiraterone. And enzalutamide is a very important drug, which is effective for cancer cells of TNBC, which are positive for androgen receptor. So this is a tourist place in the same city. Om Shanti Bhavan is a beautiful tourist place. You can experience meditation in this place when you go to that city. And the next one is TNBC versus the Ki67. You all must be knowing that Ki67 is a proliferation marker, right? So Ki67 is a marker for aggressiveness with poor outcome, and a high Ki67 is a poor prognostic marker, and the cutoff of Ki67 is more than 40% is associated with greater risk of recurrence. So I have a picture from this article where we can see the nuclear positivity for Ki67. You all must be knowing, when we talk about IHCs, whether it is ERPR, HER2/neu, 44, AR, or anyone else, it is either negative or positive, 1+ or 2+. But in Ki67, there is nothing like negative or positive. Ki67, we always give in percentage, that how many percentage of cells are Ki67 positive. So I have a very important question for some people listening out here. What is IHC4? Any one of you? This you all must be knowing, especially the residents. You will be asked this question in your Viva. What is IHC4? Because it is routinely come into practice now while signing on breast cancer reports. Anyone have any idea about IHC4? Yes. So as we do ERPR, HER2/neu in routine, we also do Ki67 routine. So it is a routine, like not IHC3 but 4. That is the Ki67 is the fourth IHC which is coming in routine. We always do ERPR, HER2/neu, and Ki67 while signing out the breast cancer reports, because we need to have the proliferation index of that. And we always write ER positive, negative, PR positive, negative, HER2/neu 1, 2, or 3+, and Ki67 in the percentage. Like recently, when I was signing out breast cancer report, I found out Ki67 is 19%, 20%, sometimes 10%. So we always write the percentage of Ki67. So this is one proliferation marker which has come into the routine practice, and we always do that. And the last most important of TNBC versus the BRCA1 and 2. TNBC has high prevalence of BRCA mutation. Again, why we are talking about BRCA1? Because of the therapies. These type of patients who have BRCA1 mutation, they respond to PARP inhibitors. So that is very important. Poly-ADP ribose polymerase inhibitors. Okay. So IDC with medullary-like features and spindle cell metaplastic types are positive for BRCA1. And the cells which are positive for BRCA1, they express CK56414 and they are consistent with basal-like pattern. So this is a very important point I would like to tell you. Blue circle of TNBC, positive for basal-like is this area. Okay. Similarly, basal-like type of cancer by molecular subtype, which are TNBC, this area. This is a green circle of BRCA mutation. But you can see the darker green area in between. This darker green area is TNBC, which is basal-like and which has BRCA mutation as well. This is the point I was telling about, the last line, which is CK56 positive and 414 positive. Okay, so these category of patients, which are TNBC with BRCA, CK56 positive, 414 positive, and they belong to basal-like also. So this is a few category of patients which has the properties of TNBC as well, basal-like as well, and BRCA-like as well. Okay. So as we talked about the IHC patterns of TNBC, we talked about ER/PR HER2/neu, which is negative in that. We talked about cancer stem cell markers, 44, 133, 49F. We talked about androgen receptors. We talked about PDL1, Ki67, and BRCA1 and 2. But other IHC patterns which must be positive in cases, these are EGFR, CK56, 14, and 17. They are negative, as we all know, this is negative. AR is negative in 41% of cases and positive in 60% of cases. TNBC do not express GATA3, do not express SOX10, and mammoglobin and GCTFP50. Okay. So now the most important aspect of TNBC is TILs, that is tumor infiltrative lymphocytes. Single liner, single take-home message is that high the TILs, the better is the response. High the TILs, the better is the prognosis. Okay. So TNBC patients with high TIL, they showed a higher rate of pathological response to treatment. TN patient with high TIL showed better short-term and long-term prognosis. Okay, and the patient who had distant metastasis, patient who had fibrosis, they showed small amount of lymphocytic infiltrate. So whenever you are going to sign out breast cancer reports, I think we can make it a habit. I have inculcated that habit in my signing out pattern, that when I always give report according to the CAP pattern, that is College of American Pathology. And I always mention the TILs. We have started mentioning TILs in that, whether the tumor infiltrating lymphocytes are present or not, high TIL or low TIL. So one question I think it should come from the audience is that what is the cutoff of TILs? There is no cutoff of TILs. We always just say that it is present or absent, it is high or low, but as such, there's no specific well-established cutoff percentage of TILs here. But I think we can start putting down TILs in that. So I'm taking a pause here. Some things we can inculcate from today in breast cancer signing out. We should give reports according to CAP protocol. You all must be doing it. We should do IHC4, that is ER, PR, HER2/neu, and Ki67 as well. We should give percentage of Ki67, and we should also mention TILs in our reports. So the place I have been showing you all this time is Mount Abu, Rajasthan. It's a beautiful place which is close to my heart, and I very frequently visit this place. And the pictures I was showing you all this time were from the same place. So the prognostic factors of TNBC, as I told you, TNBC is an unfavorable outcome. It is an aggressive tumor. It has a poor prognosis. But some factors which have a good prognosis is TILs. So the tumors which are rich with TILs, that is tumor infiltrating lymphocytes, and no fibrosis, are associated with better survival. The unfavorable factors: large tumor size, large N, and high histological grade, and presence of LVI, that is lymphovascular invasion. Okay, and central necrotizing subtype of high-grade IDC also has poor prognosis. So a breast cancer which is having a big tumor, which have high nodal stage like N1, N2, which has high grade 3, which has LVI, and which has ER, PR, HER2/neu negative, is definitely going to have an unfavorable prognosis. So talking about the treatment, we are coming to the end of our presentation now. I have just summarized the management of TNBCs here. After doing the complete surgical excision, as we know, it doesn't respond to hormonal receptors. It doesn't respond to anti-HER2/neu drugs. But if they are PDL1 positive, these drugs are going to help the patient. Atezolizumab and Keytruda. If it is PD1 positive, pembrolizumab. If it is luminal androgen type positive, bicalutamide or enzalutamide is going to affect it. If it is basal-like, like BL1 and 2, cisplatin can help. If the TNBC cells are positive for BRCA1 mutation, the taxanes and PARP inhibitors can help. Okay, so this is one point I would like to share, but I'm not going to detail in that. So the development of drugs which target the PI3K, AKT, and mTOR pathway is an evolving field, but no well-established drug is established for the treatment of that. This is currently under the research. So summarizing our presentation for today. So what are the take-home points of triple negative breast cancer? First of all, it is not a single disease. It is an umbrella term for different morphological and molecular subtypes. There is no target therapy available because it does not benefit from hormonal therapy or anti-HER2 therapy. They are associated with low survival rate and increased risk of recurrence. These type of patients present with high histological grade, they have large tumor size and they have high nodal status. Lots of research are being done and have been done on TNBC on cancer stem cell marker, that is CD44, which I have discussed in detail with you all. And one more research which we are planning on CD133, and other cancer stem cell markers research have been done. You can see the references. And TNBC PDL1 is also being done. Why PDL1? Because of the therapy available. BRCA1 because of PARP inhibitors. AR because of drugs available. And Ki67 is a proliferation index, so we routinely do in that. So the next take-home point is the molecular subtype of that. So now we have only 4 molecular subtype: basal-like 1, 2, mesenchymal, and LAR type, that is luminal androgen receptor type. Immunomodulatory and mesenchymal stem cell type is removed from this molecular classification. So this was all about the take-home message, and further large cohort research is needed to understand the heterogeneity of tumor, triple negative breast cancer, and everyone is working hard to establish commercially available management protocols